So this video is one video in a series of videos on how to care for a patient using the CareFusion Revell ventilator. What we're going to do in this video is discuss pressure-regulated volume control, a common mode, breath mode that we use in the care of critically ill and injured patients. What we'll do in this video is we'll discuss the indications of PRVC, disadvantages and risks of pressure-regulated volume control, how pressure-regulated volume control works, how we should move a patient onto the ventilator using pressure-regulated volume control, and a common alarm that we see with pressure-regulated volume control. So, indications of pressure-regulated volume control. PRVC could be used efficiently in patients who require the lowest possible pressure and a guaranteed consistent tidal volume. Those patients who are suffering from acute lung injury or acute respiratory distress syndrome, especially if they are sedated those patients who we need to maintain a minimum peak inspiratory pressure in, those with a guaranteed, that we need to guarantee their tidal volume or minute ventilation, patients who will have a very little increased work of breathing associated with PRVC when it's being used appropriately. PRVC allows us to have a decelerating flow waveform that improves gas distribution in our patients, and PRVC allows us to have a breath-by-breath analysis to determine how well our patient is doing on the ventilator. There are some disadvantages and risks of using pressure-regulated volume control. The first is a learning curve. You are now dealing with a pressure setting and a volume setting, so two variables versus one. The upper pressure limit must be set approximately between 5 to 10 centimeters above the P-plat and then readjusted. So the practitioner needs to have some knowledge of the peak inspiratory pressure on the ventilator before we arrived and the plateau pressure before we arrived or at the time of our arrival. Pressure-regulated volume control can be quite uncomfortable for alert patients, especially if a low tidal volume is used, and it may cause a worsening auto-PEEP when pressure-regulated volume control is used. The other thing is that pressure-regulated volume control determines itself over a 3-breath setting, and so if my patient is off the ventilator circuit for very frequently, they're being suctioned frequently, they're coughing frequently, they're doing any of those kind of things, then more than likely I'm never going to achieve the volume that I want to deliver to the patient. So how does pressure-regulated volume control work? We're going to take that 3-breath sequence as an example. So as the breath advances from breath 1 to breath 3, the pressure is automatically increased to achieve the set tidal volume. Ventilators give a test breath with a pause. That ventilator test breath is initially a volume breath. The second breath will be a pressure breath, and it'll square off at the plateau pressure from the previous breath. The ventilator will not change the inspiratory pressure for more than 3 centimeters of water from one breath to the next, and the maximum available pressure level is 5 centimeters of water below the preset upper pressure limit. For more of a detailed discussion about pressure-regulated volume control, you can reference the lecture on the AirLink 2/Lifeline YouTube site, which is ventilator management. And you can also look up in the CareFusion Revell manual. 4-5 has some exclamation about pressure-regulated volume control. So let's set up PRVC on our ventilator for a patient. So when I arrive at the facility, I'm going to check their ventilator or ask their respiratory therapist or transferring RN what the peak inspiratory pressure is. I'm also going to have them check the plateau pressure. I would prefer to set up our ventilator on a test lung, and that way the ventilator goes through its 3 set breaths and starts to deliver the tidal volume that I would like to achieve. So let's say that their plateau pressure is 30. I know that a plateau pressure greater than 30 is concerning. I know that a peak inspiratory pressure greater than 40 that is consistent is also concerning. So I'm going to say that their plateau pressure is 30, and I'm going to choose to deliver my upper limit of 5 above that, and that will be 35. And I'm going to set that using my high pressure limit. And so what it's doing right now is it's actually 5 less. So my my upper limit right now is 30. So I said 35. So I'm actually going to go up to 40 right now. And so my upper limit right now is going to be 35 centimeters of water. I'm going to just, for example, just use a tidal volume, let's say of 500. And then I'm going to adjust my breath type. Pressure regulated volume control can be used in assist control mode of ventilation. It can also be used in synchronized intermittent mechanical ventilation. For a more detailed description of both modes of ventilation, you can reference that YouTube video. For this one, we're going to just use it in assist control. So I'm going to adjust my down to PRVC and choose that. And so now what the ventilator is doing is it is attempting to deliver 500 mLs of a tidal volume to a maximum pressure of 35. My goal again of using PRVC is to use the minimal amount of pressure that I need to deliver that breath. And adjust this respiratory rate to, I'm not sure what happened here. So, okay, so what is a common alarm that we see with pressure regulated volume control? I think the most common and concerning alarm is a medium priority alarm that the ventilator will give us, and it is volume limited. So I'm going to attempt to trigger a volume limited alarm and explain it. So what happens in a volume limited alarm is that my ventilator is reaching a pressure greater than 35 to deliver my volume of 500 mLs. So there's my volume limited alarm. There's also a high pressure alarm that I didn't mean to do also, but my volume limited alarm is the one that I'm looking at right there. And so again, the volume that is being administered is is 500, but it's doing that at a pressure greater than 35. So there are a couple of different actions I can take. The first action I could do is increase my pressure above 35. So for instance, I could go up to 45 and deliver that volume, hopefully, maybe, we'll see, I don't know, but possibly deliver that volume, but I'm doing so in and I'm doing so by using a higher pressure, which could be harmful to my patient. So I'm going to adjust that back down to 40. The other thing that I could probably do, or that I should consider doing, is to determine what my expiratory tidal volume is. And so I'm going to say it's 386 right there. So at a tidal volume of, with a pressure of 35, I'm able to deliver a tidal volume of 386. My patient's lungs have become much, much more tight, and they're in acute respiratory distress syndrome. So what I'm going to do is I'm going to dial down my tidal volume to 386 in this patient like we had before. And that way I'm able to deliver the tidal volume in the set pressure limit. Now I know that because I decreased my tidal volume, I also decreased my minute ventilation. And I also know that minute ventilation and in-tidal CO2 are inversely related to each other. So more than likely in this case, my in-tidal CO2 is increased, and my PaCO2 is also increased. And so I probably need to increase my minute ventilation by adjusting my respiratory rate. I would also think about getting an arterial blood gas after 20 minutes on the ventilator and determine where I'm at. What else I would do is I would probably check a plateau pressure. In checking a plateau pressure now, I want to see where I'm at. So, you know, before I was at 30, and that's why I did my upper limit of 34. To check a plateau pressure, I need to know my volumes. And so right now I'm in a pressure timing, so I need to adjust it into a volume mode of ventilation. I'm going to push my maneuvers button. It's going to say I hold. I want to push it again and it's blinking, and what it's saying at that point is, do I want to do that? And yes, I do, and so I'm going to hold it in, and that's where I'm going to see my P-plat, and it looks like I'm 25, so it looks like I could actually adjust this down to 5 above, which would be 30. You guys, this was an example of how to use pressure regulated volume control on a critically ill or injured patient, and how to care for a patient who triggers the volume limited alarm. If you have any questions or comments, please feel free to contact me, and I thank you for your time.